بسم الله الرحمن الرحيم. إن شاء الله محاضرة اليوم راح نتعرف على treatment of grossly carious teeth. In previous lectures we learned how to deal with certain type of dental caries that affect, for example, one or two surfaces. However, how we will deal with dental caries if it involves more than one surface. So we will learn about that in this lecture, inshallah. Complex restorations are the restorations that replace many surfaces of the tooth structure. We use them to replace missing tooth structure that have fractured. For example, anterior teeth, if the patient fall on his face, he might fracture most of the labial, lingual, and proximal surfaces. Also, for severely involved with caries, in posterior teeth, sometimes you will have that caries affect more than one surface, like mesial, distal, buccal, and lingual. So all the surfaces are involved. And also we use the complex restoration to restore teeth that have an existing defective restorative material. Sometimes the old restoration is very large, defective, so we need to remove the old restoration, remove the secondary caries, and then restore the tooth. Now we have many problems that will encounter us when we treat very large posterior carious lesion. Most of the occlusal contact will be restored by the restorative material, and we learned before that some materials are not mechanically have enough mechanical strength to replace the occlusal surfaces, so we need to be careful with choosing our materials. Also, the extension might be on the root surface. The root surface consists of dentin, and we have sometimes problem to place adhesive resin on dentin surfaces. So we might, in this case, choose different materials or combination of sandwich technique, combination of glass ionomer and composite. Also, when the root surface is involved, sometimes it's difficult for us to isolate. So those problems we should take them into consideration before we attempt to restore any grossly carious cavity preparation or cavity in posterior area. Now, if we will compare between ordinary class 2 and extensive cavity, as you see in those two pictures, those two molars have been restored with amalgam. The photo on the left side, you can see that we have simple class 2 that was restored with normal cavity preparation, like what we learned in previous lectures. However, the photo on the right side, you can see that most of the tooth and all the cusps has been restored with amalgam. And the extension in all direction was greater in the right photo. So we need more secondary retentive feature in the right photo, and we need more resistance form. We can't rely only on the undercut that we learned in previous lecture. We need secondary retentive form to increase the retention and the resistance of the restoration. And this is what we will speak in this about in this lecture. Inshallah, we will learn what secondary retentive groove, retentive feature that we will use in this treatment. Now, when the patient came to our clinic complaining of a grossly carious tooth, we have different stages that we need to consider before restoring the tooth to the final shape. We should make preoperative assessment, we should remove the dental caries, then we should design our restoration, and finally choose our restorative material. For preoperative assessment, of course, we need to do a clinical examination for the patient. We should know the extent of caries or the existing restoration and its relation with the gingival margin. Sometimes when we examine the tooth, we will find that the caries is extending subgingivally, and sometimes we can't reach the caries margins to place our restoration. In this case, we consider the tooth unrestorable, and we might do some surgery before we proceed with our restoration, like crown lengthening and or gingivectomy or other surgeries. Of course, also the bulb, is the bulb vital or not? We need to determine it before we proceed with our restoration. If the tooth is non-vital, we need to do endodontic treatment before we proceed with our restoration. And finally, we need to examine the occlusion in centric and lateral excursion. And this is because most of the occlusal surfaces, as we say in the beginning, might be covered by the restorative material. So you need to know the type of occlusion that is present on the tooth. After examination, we will take some radiograph as adjunct, like bite wing or periapical, and to determine, for example, the extension of caries, how much dentin is remaining between the dental caries and the bulb. Also, you can see the periapical tissue, so all of those will be evident in the X-ray. For example, bite wing will help you to determine the extension of caries from the proximal surfaces toward the bulb. After we do our pre-assessment, we need to remove the caries. We should remove all the restorations. We should access to the carious dentin. We should clean the dentin enamel junction, remove any undermined enamel, remove the caries from the bulbal wall, and at the end we might have either sound tooth structure. In this case, we do indirect bulb capping, and if we have sudden exposure, then we need to deal with direct bulb capping procedure. So dealing with deep dental caries, we can have either sound tooth structure, we can reach sound tooth structure, then we can proceed with our procedure normally, or sometimes we have left caries that we can't remove. If we remove it, we will make some bulb exposure. In this case, we call it the procedure indirect bulb capping. We will leave some part of the carious dentin in the deepest part of the cavity to prevent bulb exposure, and then we will place our liner and bases that we learned in last lecture. And if we suddenly have direct bulb capping during our work, the direct bulb or the exposure could be cause of either mechanical or caries exposure. The mechanical exposure is caused by errors from the dentist, and it's related to some procedure error done by the dentist. That's why we call it mechanical. That means the bear or the hand cutting instrument do the mechanical exposure of the bulb. And the other type is caries exposure. This done by the caries itself. That means the caries has extended to the bulb and exposed it. And it happen with you while you are removing caries dentin. You will reach the bulb and you will find the exposure. Now we will have other lectures about how to deal with bulb exposure. However, if we will use direct bulb capping, this should be in a non-symptomatic tooth structure that is clean and that the area of exposure very minimal and we can control the bleeding. Otherwise, don't try to make direct bulb capping. I will go directly to make the RCT for this tooth. And also in caries exposure, of course, you need to remove all the caries and then make RCT for the tooth, then you will proceed with your work. After that, we need to design our restoration. The design is initially indicated by the previously existing restoration or extent of caries lesion and the relation of the floor of the cavity to the gingival margin. So we make our assessment, then we remove the caries and all the old restoration. Then after that, we need to design the restoration. We need to determine the extension of the restoration. Also, we need to determine the retention form that we need and the resistance form that we need for the final restoration. And this is what we mean by designing the restoration. And designing will be affected, as we say in this slide, by previously existing restoration and the caries and also the relation to the gingival margin. As I say before, we need to make sure that we have enough space between the gingival margin and the bone level. We call this the biological width. If we have violation of the biological width, then we need some sort of periodontal surgery. Now, after we design our restoration, we need to choose our restorative material. It depends on the amount of remaining tooth structure present. You should remember that we have two types of direct restoration that you can use, most likely amalgam and composites. And glass ionomer is very weak material. You can't use it in treating grossly carious teeth. So mostly two type of direct materials, or you can go for indirect restorative material using any type of cuspal coverage. So the amalgam you can use directly either amalgam or composite, and indirectly you can use any type of cuspal coverage. We will learn about them inshallah next year. Now let's speak a little bit about amalgam. All of you know the advantage of amalgam, that it's easy to use, have high compressive strength, especially good for posterior area. It has good and excellent wear resistance, and it has a proven long-term clinical performance. However, it's anesthetic material. Because of its color, it requires retentive tooth preparation, so we need to remove more of sound tooth structure to retain the amalgam, and it doesn't seal or strengthen tooth structure. Now, the amalgam can be used for different purposes in treating grossly carious teeth. You can use it as a control restoration in teeth that have questionable pulpal or periodontal prognosis. For example, if you have one tooth that is vital, has irreversible pulpitis symptoms, for example, let's say lower molar tooth, and it has a grossly carious lesion. What we will do is removal of the caries, and then we will restore it with amalgam. Now we need to protect the pulp from the oral cavity and prevent the progression of the reversible pulpitis to irreversible pulpitis. Also, we need to provide anatomical contour which provide good gingival health for the tooth, and also facilitate control of caries and plaque. And finally, provide some resistance against tooth fracture. After that, we will follow the tooth to determine the pulpal and periodontal prognosis. If we leave the tooth in the same situation that we saw it in the beginning, then the tooth will progress into pulpitis, and then it will need RCT, and it also might have some periodontal problem. That's why we use the amalgam in this case as a controlled restoration to determine a questionable pulpal and periodontal prognosis. The pulp might be protected, and then we will consider this restoration as a final restoration, or sometimes we will go and do some RCT or some perio treatment for this tooth after a period of time. Also, we can use amalgam as a control restoration in teeth that doesn't have any symptoms, but it has acute or severe caries. So we will place the amalgam and consider it as a control. We will make follow-up for the tooth and determine afterward if it needs further treatment. Also, we can use it as a definitive final restoration. If we can remove all the caries and we can place some retention and resistance form and build the tooth to the final shape, then you can consider it as a definitive final restoration. And finally, we can use it as a foundation under an indirect restoration. That means we restore the tooth with amalgam, then we will cut it back and place indirect restoration above it. Now we have some contraindication for using amalgam for severely carious teeth. If the tooth can't be probably restored with a direct restoration because of anatomical or functional consideration. So if the tooth is non-restorable with direct restoration, you can't use amalgam. And the patient has significant occlusal problem. That means it's difficult to use direct restoration, which mandates to place indirect restoration. And if the area to be restored is aesthetically important, for example, anterior area, you can't use amalgam. Now, what are the treatment options that we have to use amalgam as a restorative material for grossly carious teeth? We should remember that we need large mechanical retention for amalgam because those restorations are large. So we can use some different type of secondary retention, like using pins, slots. Sometimes we can use amalgam, as we say, as a foundation, then place indirect restoration, or sometimes recently they use something called bonded amalgam. We should aim to bond the amalgam to the tooth structure, so it will have a retention like micromechanical retention, like the retention done with composite. So we'll learn about all those types of retention in this lecture, inshallah. Now let's speak about pin retained amalgam restoration. Those are amalgam restoration requiring the placement of one or more pins in dentin to provide adequate retention and or resistance form. as you see in those photos, that we have different type of pins or different number of pins placed in each tooth. You can see that we don't have enough tooth structure. That's why we place those pins in dentin to try to retain our final restoration. Generally, pins are placed whenever satisfactory retention and resistance form can't be established with other means. This means you should try first to place grooves, undercuts, slots, any other retention mean that we learned in the lab. If you can't place those retention means because of the remaining tooth structure is minimal, then you will proceed and use the pins. So try to leave it at the end because it's not easy to place pins, as we will learn now, and sometimes we have many complications with using pen. So it's the last type of retention that you should think of for retaining your restoration. Now we have different types of pens. Three main types. The first one called cemented. The second one is called the friction lock, and the last one is the self-threading pen. We will learn about each type now. The cemented pen, first described in 1958 by Markley. Those are pens that will be cemented in place. This means you will prepare the pen hole. هو مكان دخول البن. The pen hole will be prepared with a burr. But the hole should be larger than the pen size. يعني الفتحة اللي بنحفرها عشان يدخل فيها البن لازم يكون حجمها أكبر من البن نفسه، فبالتالي يكون في عندك فراغ مناسب حتى تعمل إلصاق أو cementation for this pen in this hole. So the thread or serrated SS pen cemented into a pen hole prepared almost 0.025 millimeter, larger than the diameter of the pen, so we will have a space for the cement. Those pen holes usually deep, they are 3 to 4 millimeter in dentin to provide enough space for or enough length for cementing those pens in place, so we will guarantee that they will not come out. The cement that we will use is usually zinc phosphate, polycarboxylate, glass ionomer, whatever type of cement that we learned before. However, it doesn't cause stresses or crease line in dentin. This is a good advantage of those materials or those pens. They will not produce any stresses in dentin because you will not place them forcefully inside dentin. You will just cement them in place. However, they are least retentive. So they produce good, or they produce less stresses in dentin. However, they are not that retentive. That's why we have the second type, the friction locked pens, described by Goldstein, and this was in 1966. Those pens differ than cemented pen. The pen hole should be smaller than the diameter of the pen by 0.025 millimeter, and they are usually placed by tapping into place, and they will be retained by the resiliency of dentin. إذا بدكم تتخيلوا هو تقريبا زي كيف تضرب مسمار جوا الحيط، نفس الإشي. You will tap on it until it enter inside dentin. It's more retentive. However, it will produce some stresses in dentin because you will tap it in place. Now, the more retentive type of pen than the friction lock is the self-threading pens. Those also was described in the same year, 1966, by Goin. The diameter also is of the pen hole is smaller than the pen itself. It will retained by threads that will engage the resiliency of dentin. So you will screw this type of pen inside dentin, and it has the depth of the pen hole is smaller than the friction lock. However, this type of pen is more retentive. It's the most retentive of the three type of pens. It's 5 to 6 times more retentive. However, it will produce lateral and apical stresses because it will be threaded in place. تقريبا هاي شكلها زي البرغي، يعني بدك كيف بتحط البرغي جوا الحيط، بدك تستعمل مفك إله. هون نفس الإشي عندنا أدوات we call it a screw drive that will place this pin and engage it in dentin by threading. طبعا stresses is very large. The most common type is a thread-made system. الستريسز ممكن تعمل لك مشكلة بالدنتين، ممكن تعمل لنا reversible bulbitis، ممكن تعمل perforation، ممكن تعمل exposure للبلب. So it's retentive, however it will produce some disadvantages on the bulb, and this is what we will learn now. We have some problems associated with pin placement. The main problem are difficulty to place in posterior teeth because it's difficult to isolate, it's difficult to see probably, especially the orientation of our bear in the posterior area. Patient apprehension during placement. It's sometimes difficult to tell the patient that we will place those pins inside dentin, especially the friction lock and the self-threading, because you will place them forcefully in dentin. And also the stresses that we speak about are created in dentin, causing lateral cracks perpendicular to the long axis of the pin and shearing forces apical to the leading edge of the pin. So those stresses are dangerous to the dentin and might affect the bulb health afterward. Now, if we decide that we need to place pins for retaining or restoration, then we should consider some factors. We should know the resistance and retention form that we need. We should determine the status and prognosis of the tooth that we will place pins inside. We should consider the role of the tooth in the overall treatment, because we are not treating this tooth only. We should have a general treatment plan. We should determine the occlusion, aesthetic, and economy of this treatment, and finally the age of the patient. So about retention and resistance form using pins, this depends on two factors: the number of pins that we are using and the location. Now, concerning the number of pins, it's dictated by the amount of tooth structure remaining and the missing. And as a general rule, we usually use one pin for each missing cusp of the tooth. However, increasing the number of pins will decrease the resistance form for amalgam. So you need to consider the retention and resistance form together. For example, if you have a tooth structure that you can place pin in two area of cusps that are missing, and you can use, for example, undercut on the other area, I will try to minimize the number of pins that I am using, because it's a factor of two-way. It will increase the retention, however, it will decrease the resistance. So you need to choose your retention and resistance form carefully, depending on the remaining tooth structure that is present and how much tooth structure missing in your cavity preparation. Now, the location of the pin hole from the external surface depend on the external morphology of the tooth, the type of restoration that we will place, for example, direct or indirect. Indirect restoration, we will use the amalgam as a final restoration. In indirect restoration, we will place the amalgam, for example, and then we will remove part of it, almost 1 millimeter all around, to prepare space for indirect restoration. In this case, maybe you need to place your pins more axially to be able or to make the pin not removed during preparation for the final indirect restoration. And finally, the type of the margin to be prepared. And this is also related to indirect restoration. For example, we have different margins of finish line that we will prepare. Some are chamfer, some are shoulder, depending on the final material, either metal coverage or, for example, porcelain fused to metal or all ceramic restoration. So those 2 points, number 2 and 3, they depend on the, or they are used for indirect restoration. And we will learn about them next year, inshallah, in Crown and Bridge Lab. We will concentrate today on the external morphology of the tooth when we are trying to place pins in restoration that will be final restoration, not covered with indirect restoration. So our location of the pin will depend on the external morphology of the tooth. Let's look at this schematic view. Now in this view you can see that we have maxillary molar, mandibular molar and maxillary premolar. The best area to place your pen is in the dotted area, the gray dotted area, which is the line angles. It's the position of the cusp. You can see that in each tooth of those, the area of presence of the cusp is the most preferred area, and it's presented here by dotted line. Now the white area on each tooth represent either concavity, furcation, or thin dentin area. So you need to be careful of placing your pen in the white area in each type or on each side of the tooth. For example, the maxillary molar, remember that we have three roots: palatal root and mesobuccal and distobuccal root. So you can see that the white area represents the furcation position for or between those roots. So it's very dangerous to place your pen in furcation area. You might do perforation into the periodontium if you place them here. The same apply for mandibular molar and maxillary premolar. Now the gray area present in the maxillary molar on the lingual surface and the mandibular molar on the distal surface, this represent a dangerous area. If you don't have other than this place to place your pen, then you should be very careful. This area represents an angulation of the root in relation to the crown. So sometimes we have severe angulation between the root and crown, so it might be sometimes dangerous to place pen in this area. However, this depends on the anatomy, so if you don't have any other location to place your pen, you might use them very carefully, but you need to have good x-rays to determine the angulation between the crown and the root. Now this is all about retention and resistance form using pen. Now let's speak about the status and prognosis of the tooth that we will place pen inside it. So if the tooth has symptoms or sensitive, then we can't place actually pens inside it. We should treat the cause of sensitivity or symptoms, then we will consider the final treatment afterward. Also, if the tooth is RCT treated, so it's not recommended to use pens in treating those teeth. Those teeth can be restored better with Bost, and there is special lecture about using Bost in treatment of endodontically treated teeth. So if the tooth has RCT or has been treated by RCT, don't place pens on those teeth. Also, as we said before, if the tooth is non-restorable and the gingival margin are so deep, we can't place matrix band to have our final restoration. We consider those teeth are as non-restorable, and it's difficult to place pens on them. So from the beginning, determine the status and the prognosis of the tooth that you will place pen inside it. The role of the tooth in the overall treatment, as we say, we have final treatment plan that involve a treatment for each tooth the patient has. So pen retained amalgam restoration is not a treatment of choice for teeth that must serve as an abutment for a removable partial denture. If you will make removable partial denture afterward for the patient, it's not advisable to place pens in abutment teeth. And also pens are contraindicated in teeth that require elaborate occlusal alteration. If you will change the occlusal occlusion on this tooth, or you will have elaborate occlusal alteration or full mouth rehabilitation, it's better not to use pens because they will provide more stresses on the tooth structure that you are treating. And finally, the aesthetic. When aesthetic are of prime concern, pen retained amalgam could be contraindicated. So you need from the beginning to determine the aesthetic. This doesn't mean that we use amalgam in aesthetic restoration. However, we are speaking on, for example, posterior teeth like premolars. If part of this premolar, for example, shows when the patient smile, we consider this an smile or an aesthetic problem. Another example, some patients, when they smile, most of their upper premolars and mesial part of upper molars, they might be shown. So if you will have this situation, it's better not to use pen retention and also not to use amalgam at all in those teeth. And then I will try to consider using composite to treat those grossly carious molar and premolars. Now about the costs, if we compare the bin retained amalgam restoration to the indirect restoration, then the cost is a major factor and bin retained amalgam is appropriate treatment. It's cheaper than indirect restoration, provided that acceptable restoration could be achieved. This depends on your skills. If you can build all the cusps and retain the normal anatomy to be functional and aesthetic for the patient, then you can use amalgam and it's cheaper and it's a good choice for the patient. However, if you don't have those skills to retain the tooth to the normal shape and you need to place an indirect restoration, you should consider the cost and tell the patient about the cost of the final restoration. And finally, about the age of the patient, for some geriatric or debilitated patient, this could be the treatment of choice over the more expensive and time-consuming cast restoration. As we say, it's a cheap treatment and also it's good for old patients. You can place your amalgam in the same day without many visits for the patient. However, indirect restoration might need many visits from the patient. You need to prepare the tooth, take impressions, send it to the lab, then try it, and finally cement it for the patient. So old people, they might be unable to come many times to your clinic. For young patients, the placement of pen could provide a risk at the bulb chamber because they are large and it might be easy to penetrate the pen inside the bulb. So for young patients, it's not recommended to place pens because the bulb chamber is very large and you might end in doing a perforation inside the bulb. And after that, you will have more complication and you might need endo treatment. So young patients, try not to place pins inside their teeth to restore it. Now the advantage of the pin retained amalgam restoration, as we compared it previously to the indirect restoration, it's more conservative, the gingival margin could be healthier, it's less time consuming, in one visit you can do it, it's relatively economical, cheaper than indirect restoration, and the retention and in some cases resistance form can be improved. So it has some advantage, however, it still have some disadvantage. The proper contour and occlusal contact are sometimes difficult to achieve, and this is because you do it directly. It depends on your skills. Amalgam set very fast. You have like almost 10 to 15 minutes to prepare all the anatomy, so it's sometimes difficult. Drilling of pinholes and placement of pins could create some internal stresses in dentin, and this might affect the vitality of the bulb. And finally, micro leakage around all type of pins has been demonstrated, so there will be still some micro leakage around those pins. Therefore, we might have a problem in the tooth afterward, after we treating it with pin retained amalgam. The patient might have sensitivity, might have secondary caries, might have dislodgement of those pins, sometimes sensitivity and pain that mandate more treatment of the dental pulp. Now there is some things I want you to consider before placing pins and to understand them very well. Pins do not reinforce the amalgam, so they are not a reinforcement procedure. Therefore, they do not increase the strength of the restoration. There is no increase in compressive strength, and there is significant decrease in tensile strength. So don't say that bends are for strengthening the amalgam restoration. They don't strengthen the restoration. They are just for retention of the restoration. And also, there is increased risk of perforation to the bulb or the external tooth surface unless the procedure is knowledgeable and skillfully done. Don't place pins unless you have the required skills. If you don't have the required skills, don't place pins for retention. Try to find other means for retaining your restoration. Now, there is many factors affect the retention of the pen in dentin and amalgam. For example, the type of pen, we say that self-threading is more retentive than friction lock, more retentive than cemented. So the type you will choose is one factor. Second, surface characteristic of the pen. Retention of amalgam onto the pen. For example, self-threading has more surface characteristic. That's why it's more retentive. Followed by cemented, followed by the friction lock. Friction locks sometimes they come like a very flat surface, so there is not that much self characteristic on the pen. There is no bonding between the amalgam and the pen, and there is pure mechanical retention. That's why we sometimes, if to increase the retention, we change the orientation of the pen. If you place every two opposing pens in different orientation, you might increase the retention of the restoration that you have. It's exactly the same concept as the two opposing walls in any cavity preparation. If you will increase the retention for amalgam, you should provide some convergence in any two opposing walls. The same applied for any opposing two pens. Try to change the orientation between them and make them more converging, not parallel to each other or diverging. The number of pens, we say if you increase the number of pen, you will increase the retention. However, this will affect your strength and your resistance to fracture. Also, the diameter of the pen will limit as the diameter increase, retention, amalgam, and dentin increase. However, also it will have more dangerous. You might have more problem in dentin, and also you might have decrease in the resistance form required for amalgam. And finally, the length of pen into dentin and restorative material. With cemented pen, retention increases linearly with increasing the pinhole depth. That's why we say the pinhole for cemented pen are usually longer than the other two types because you are depending on the cement layer and you need a longer pinhole to retain the pen you drill in dentin. However, with the friction lock and cemented pen, there is no real benefit of increasing the pinhole depth beyond 2 mm because they are retained by engaging the resiliency of dentin. So don't prepare longer than 1.5 to 2 mm for those two type of pens. Now we have some failure of pen retained restoration. The failure could happen at any 5 location of those. It could within the restoration itself, and we will have fracture of the restoration. It could be at the interface between the pen and the restorative material. The material could pull off and the pen stay in place. It could be within the pen itself. The pen can fracture when stress is beyond its limit. If you have a lot of stresses on the pen might fracture. At the interface between the pen and the dentin, and the pen can pull out of the dentin. And finally, within the dentin itself, the dentin will fracture. Now, number 4 is the most common type of failure, except with the friction lock pens. Now, let's learn about the problem that will encounter us when we are trying to do the pen retained amalgam. Sometimes we will have broken drills or broken pens. And this happens if stressed laterally or allowed to stop before removed from the pinhole. If you carry the drill and you stress it laterally against the dentin, or if you stop the engine before you remove it from dentin, it might stuck in the dentin and fracture. Sometimes the removal of the broken piece is difficult and should not be attempted because most the pen or the part of the drill that prepare the cavity is very minimal. It's like 2 mm. So if it fracture, it will fracture all of it with a fracture and stay in dentin. So in those teeth, they are actually compromised teeth. So it's not advisable to drill around this drill and try to remove it. Leave it in place. Prevention is the best solution. However, you can choose a safe place away, like from the area of fracture by 1.5 millimeter, and then you will drill another hole for a new pin. Don't try to remove the fractured pin or the fractured drill. leave it in a place and try to find other place to place a new pin hole and a new pin. Sometimes we will have loose pin after we prepare our pin hole and place our pin. The pin is not retentive, especially with friction lock and the self-threading pins. And this happens by two ways. Usually because the pin doesn't properly engage dentin, or the pin hole is too large with the friction lock and self-threading pins. And sometimes pin could be loosened when attempt to shorten them with a pair. Sometimes when we place our pin, we will find that it's very high and it will interfere with the occlusion. So what we do usually is to cut part of the pin with a pair, and this procedure might make the pin loose and it will lose its retention. Now, if this happens with us, the solution will be that the pin should be removed and one of the following procedure can be done. Either the pin hole is prepared with the next largest size drill, you will use larger pin, or the depth is increased to 3 to 4 millimeter, and then you will cement this pin in place. So you can choose whatever is best for you in this clinical situation. Now, the most dangerous problem that will encounter us during placing of men is penetration or perforation. Penetration into the pulp or perforation of the external surface. كيف بدنا نعرف إنه صار في عنا penetration or perforation؟ طبعا رح يصير في عندك ممكن يصير في عندك دم بيطلع من ال pin hole. So hemorrhage in the pin hole following removal of the drill might show. Sometimes the operator can tell from their tactile sensation. So your hand can tell if you have perforation or pulp penetration. Also, sometimes if you insert your pin and it's enter more than 2 millimeter depth, then you can see that there is a problem. Either you are entering inside the bulb or you are screwing it outside the structure. Also, observation of the angulation of the drill should indicate whether a pulpal or external penetration has occurred. كيف بدنا نحدد إنه صار في عندي مشكلة باتجاه البلب أو بالبريدونتال تيشو؟ عن طريق الأورينتيشن الأنجوليشن اللي أنا استعملته في أثناء وضع هاي الدنتال بين side the dentin. So I need to observe the angulation to determine. However, I need to take a radiograph to determine what happened. Radiograph can verify if pulpal penetration has not occurred, if there is some dentin between the bulb and the pin. يعني صورة الأشعة بتقدر تأكد لك إنه ما صار في عندك bulb penetration إذا كان في عندك sound dentin ما بين البن والdental bulb. However, any view projecting the pin in the same region as the bulb doesn't necessarily mean pulpal penetration. It might be an overlap as a result of angulation. فإذا كان صورة الأشعة بينت لك إنه البن داخل البلب، هذا لا يعني إنه في عنا bulb penetration، لأنه ممكن يكون في عنا overlap. ممكن البن جاي بقل أو لينجول للبلب، فبس تأخذ صورة الأشعة رح يبين البن داخل البلب. فالراديوغراف can verify if pulpal penetration has not occurred. Any radiograph that show the pin projecting outside the tooth confirm external penetration. إذا أخذنا صورة أشعة ومبين إنه البن زي ما شايفين بالصورة طالع من السن، معناته إحنا وين حاطينه we make a penetration inside the periodontal tissues. However, any radiograph showing the pin inside the projected outline of the tooth doesn't exclude the possibility of the perforation. يعني إذا أخذنا صورة الأشعة ومبين إنه البن مش طالع من حدود السن الموجودة عندنا، هذا لا يمنع إنه في عنا penetration. يعني أنا حطيت البن في عندي bleeding بيطلع، لكن أخذت صورة أشعة لقيت إنه البن موجود within contour of the tooth structure. هذا لا يمنع إنه أنا عملت perforation إما بقل أو lingual tooth، مش شرط يكون على proximal surfaces أو away from the contour of the tooth. فأخذ صورة الأشعة ممكن يساعد في تحديد المشكلة اللي صارت عندنا. كيف ممكن نحل المشكلة إذا صار في عندي penetration or perforation? In any asymptomatic tooth, a pulpal penetration is treated as any other mechanical exposure. فرح نعامله زي any mechanical exposure. It's an asymptomatic clean cavity. minimal exposure you can control the bleeding. You will place direct wall capping. إذا ما قدرت تسيطر على البليدنج راح نروح ل RCT treatment. Now the problem with perforation, if we perforate into the external wall of the tooth, we should examine clinically by probing and by radiograph to determine location of perforation. لازم نحدد موقع البرفوريشن احنا عملناه. هل هو under gingival attachment or over the gingival attachment. If the perforation located occlusal to the gingival attachment, then cut the pin flush with the tooth surface. The pin will removed and the pinhole will be restored and the pin cut or the pin will be cut and the tooth prepared beyond the perforation. يعني إذا صار عندك البرفوريشن في الجزء من السن اللي هو فوق الجنجيفال اتاتشمنت، يعني أنت بتقدر تشوفه أصلا. ففي هاي الحالة عندك ثلاث خيارات: إما بتقص البن من برا and make it flush with the tooth surface، أو إنه بتقيم البن وتسكر الفتحة اللي أنت عملتها عشان تحط فيها البن، أو إنه بتقص البن من برا cut it from the outside and then prepare the tooth beyond perforation. هذا في حالات indirect restoration when لما نحط تاج على السن اللي احنا بنحضره راح ننزل الفينش لاين شوي عن المنطقة اللي صار فيها perforation. So again, perforation located occlusal to the gingival attachment, we have a three way to deal with it: either to cut the pin flush with the tooth surface, or if we can, remove the pin and restore the pinhole with any type of restoration, or the restoration that we will place like composite or glass ionomer. And the third situation, when you place indirect restoration, the pin will be cut and then your preparation or the finish line will be prepared beyond the perforation area. It will be gingival than the perforation area. So those if the perforation located closer to the gingival attachment. Now what will happen if it's under the gingival attachment, apical to the gingival attachment? In this area it's deep, we can't see it by our eyes. We need to reflect the gingival. Surgically, we need to expose the pinhole, enlarge the pinhole and restore it with restoration, or we should perform a crown lengthening and place the margin of the restoration gingival to the perforation, and this is in the case of indirect restoration. We will do surgery, this is the perio surgery I speak about. We will do crown lengthening and then place our margin of the restoration, the final indirect restoration, gingival to the perforation. So our finish line will be a little bit deeper than the perforation area. Now, as a summary for what we speak about in this lecture is we are dealing with the grossly carious teeth. We will place complex restoration that will involve many surfaces of the tooth. We speak first about amalgam, and we say amalgam, complex amalgam need more retention. We need more retention than the what we learn in the lab about retention groove and indirect or undercut placement. We speak about the different type. The first type we speak about is pin retention. Now we will continue with other type of retentions. The slot retained amalgam restoration for complex restoration. A slot is a retention groove placed in dentin in a horizontal plane. As you see in this photo or in this schematic view, that we place a large retention groove in a horizontal plane. It may be used in conjunction with pin retention or as alternative to it. So if you can place, for example, one pin in area that you can't place a slot, and other area you can place a slot. So you can use it in combination or alone from using pins. They are particularly indicated in short clinical crowns and in cusps that have been reduced 2 to 3 millimeter for amalgam. Now remember, when we place pins, actually we need to have 2 millimeter of the pin inside dentin, 2 millimeter of the pin in the amalgam, and we should have a clearance, or the pen should be away from occlusion by 2 millimeter. So if we don't have this 6 millimeter space to place a pen, it's better not to use pens. And in this case, we will use slots. So in short, clinical crown that we can't offer 6 millimeter space or length for placing pen, we should use slot retention groove rather than pens. Also, when we place indirect restoration, we need to make occlusal reduction by 2 to 3 millimeter to place our final restoration. And in this case, if you didn't have this space for placing pins, then you will use a slot retention. فإذا بدنا نحط تاج على السن بعد ما نحضر الأمالجم لازم يكون في عندك 2 mm for the pin inside dentin, 2 mm in the amalgam, and 4 to 5 mm occlusal clearance between the pin and the occlusal surface. إذا ما كان موجود عندنا في هذا السبيس بالنسبة للindirect restoration برضو ما بقدر أستعمل pins، لازم أستعمل slots. Now, if we compare the slots to pins, we have more tooth structure will be removed with the slots than pins, because we are preparing horizontal retention groove, so we remove more sound tooth structure when we prepare slots. However, slots are less likely to create microfracture and less likely to perforate the tooth or penetrate the pulp. So we have some advantage and disadvantage of using slots, and the choice of using pins or slots, as we say, depend on each clinical situation. You should determine the retention and resistance that you need, and the amount of remaining tooth structure, and the final restoration that you will use. So refer to the beginning of the lecture and see what we should consider before choosing any type of retention. Now, about the preparation of slots. Usually we place them on any aspect of the preparation. They could be either continuous all around the tooth, or they could be segmented, as you see in this schematic view. This depends on the amount of tooth structure missing and whether pins are to be used or not, depend on the other type of retention grooves. Sometimes if you place those retention groove not in a horizontal plane but in a vertical plane, you can, we call them cuffs, as you see in this schematic view. Now the depth of them should be at least 0.5 to 1 millimeter in dentin, and they should be placed in the gingival floor, 0.5 millimeter axial to the dentino-enamel junction, and this is in case that we are using direct restoration as a final restoration. So they should be 0.5 millimeter axial to the dentino-enamel junction in case of direct final restoration. In case of indirect final restoration, they should be more than 0.5 millimeter, and we will speak about later on when we speak about using slot retained foundation restoration. So far we speak about pin retained amalgam, we speak about slot retained amalgam. Now we will speak about amalgam foundation. Amalgam foundation are not a restoration that will be used as a final restoration. It will be covered by indirect crown or indirect bridge. So those foundations will not be in occlusion with opposing teeth. They will be covered by indirect restoration. So those materials or those restoration are the initial restorations of a severely involved teeth. The tooth is restored so that the restorative materials will serve in place of the missing tooth structure to provide retention and resistance form for the replacement of the definitive indirect restoration. It should provide resistance against forces that might fracture the remaining tooth structure. So again, they will be covered by indirect restoration. The control restoration may serve as a foundation. As we say, amalgam can be used as a control until we determine the prognosis and the status of the bulb and periodontal tissue. So if you place the amalgam and you find that everything is okay, you can use the control restoration as a foundation. You don't need to replace it. The restorative material used for foundation are either amalgam composite and resin modified glass ionomers, and retentive means may be required like pins, slots, and posts. So again, we are replacing amalgam under indirect restoration. Now to retain the amalgam in the tooth before we place the crown above it, we need to retain the amalgam using the same retention means. If you can place retention grooves, you can use undercuts. If not, you will use pins, slots, and posts. So this will be called now pin retained foundation or slot retained foundation. If the tooth is RCT treated, it will be called post retained foundation. Okay, I hope it's clear. If it's not clear, you can send me an email to ask about what you want. Now let's speak about tooth preparation for amalgam foundation. As we say, amalgam foundation will be covered with indirect restoration. Now we need to retain first the amalgam in the tooth structure before we prepare it to receive indirect restoration. So we need retention, and the retention is the same. Either we will use pins, slots, or chamber retention from the bulb chamber if it's very deep. Now if we will use pins to retain the foundation, we use it in severely broken teeth with a few or no vertical walls when an indirect restoration is indicated. So we don't have any vertical wall present. We only have a small amount of tooth structure above the gingival, so you need to place pins. We will consider all the factors that we speak about previously. However, we will take into consideration that the distance of pinhole from the external surface of the tooth should be more, because we need to prepare 1 millimeter all around or 1.5 millimeter all around of the tooth structure to receive the indirect restoration. So the pin should be more toward the central of the surface of the or more toward the central of the tooth. They should be away from the external surfaces of the tooth more than the placement of direct restoration. يعني الفرق ما بين البن retained amalgam restoration والبن retained amalgam foundation اللي هو البوزيشن تبع البن عادة لازم نبعد عن external surfaces by 0.5 أو عن dentin enamel junction by 0.5 ل 1 ملم في النورمال situation. إذا كنا بدنا نحط indirect restoration على السن نستعمل الحشوة كفاونديشن. Now, after we finish the design, placing the retention features, we will start our procedure. We place our matrix band and we say you have different choices. You will choose whatever is present in the clinic and convenient for you. You will place your wedge. Now, this preparation has been or will be restored with bonded restoration. That's why sometimes we apply some petroleum jelly to the band to aid in its removal. It will not stick to the cement itself, or sorry, to the bonding agent. Now you can either use total etch of the test structure, or you can use self-etching primer. It depends also on whatever you have in the clinic. After you apply your etching, you will wash the surface and dry the tooth structure. Then you will place your bonding agent. The bonding agent should be chemically, or we call it self-cured resin, adhesive cement. It should not be light cured. We will apply it to the tooth structure with a micro brush, and then after that we will start condensing our amalgam. The amalgam will be condensed in the cavity. We should take care to fill the cavity to the height of the cusps of adjacent teeth, and excess amalgam should be removed around the margins, as you see by the yellow arrow. Now, when you condense the amalgam above unset resin, unset bonding agent, as we say, there will be interlap, or the amalgam will be mixed with the unset bonding agent, and then the bonding agent will set finally, and there will be interlock between them. After that, you will remove your matrix. You will start carving your cusp. You should determine first where is the cusp, where is the foci, where is the grooves will be. And as I say, it needs many practice. It will not come from the first attempt, so you need to do many complex amalgams to be able to have at the end a good shape, final shape, final correct position for the cusps, grooves, foci, central fissure, secondary fissures. So those treatments are difficult to do. They need a lot of knowledge, a lot of skills. In the present materials, the present material or recent material present in our clinic, maybe make it easier to use composite rather than amalgam. However, as we say, amalgam has some advantage. They are cheap. If sometimes we don't have them we don't have composites in farther area or area that away from the central, so you need to use amalgam. So it's still a choice that is present, although it's difficult to use. Recently, if you have composite in your clinic, it's better to use composites. They are easier to use, more convenient to prepare. You can correct the occlusion by yourself at the end without having problem that the material is set. So composite can be used as a treatment for complex restoration, either anterior or posterior, as you see in this photo that we have large caries, grossly carious tooth in the anterior area. The caries involve most of the surfaces of the tooth. Of course, this is not an area indicated for using amalgam, so we'll use composite. Sometimes we can use composite with combination with a glass or resin modified glass ionomer. In the sandwich technique, you can first remove all the caries, prepare the tooth to receive resin modified glass ionomer, and after that you remove part of glass ionomer and use composite to have better aesthetic. We call those sandwich techniques. Now there is indication for using composite in treating grossly carious teeth. They have the ability to strengthen weakened tooth structure, and in term restoration they can be used as controlled restoration like amalgam while waiting to determine bulb response if we need further treatment for the bulb, and also they can be used as a foundation for indirect restoration. For very large restoration, secondary retention is usually required. with composite, you remember, we usually use either retention grooves or bevel if we have enough margin. However, we don't have those available every time. So we need, for larger restoration, secondary retention, because there is increased amount of missing tooth structure. We have decreased amount of tooth structure available for bonding. As I say, we don't have enamel always. And the increased concern for retaining the composite in the tooth. When we don't have enough enamel, we have mostly dentin. The bonding to dentin is sometimes difficult, as we will learn in other lectures. So we need to treat the composite as amalgam. We need certain mechanical retention, also as a supplement for the mechanical retention with dentin. And the retentive means that we can use with amalgam is the same. We can use the grooves if we can. We can use slots in the horizontal plane, locks in the vertical plane. We can use pins. If you are, for example, using or placing composite in posterior area, if you place them in anterior area, it's actually contraindicated because the pin will be shown above or under the composite. If you will place a crown above composite, you might use pins for retention, and then you will cover all the tooth with a crown. This could be possible. You can use wider bevel or flare on accessible enamel margin to increase the surface available for bonding, and sometimes you can use root canals if the tooth has an RCT. So again, determine what retentive means that you can use to retain your restoration, and the need for direct or indirect restoration. Now, composite usually has a low wear resistance, so I prefer if you will use composite in posterior area, this should be like a foundation, should be covered with indirect restoration, because with time it will wear away, and we will lose the height of the cusp and function of the tooth. Now, the clinical technique for using composite is the same. You need to prepare the cavity. As we say, everything that apply to amalgam will apply to composite, about preoperative assessment, occlusion, preparation, resistance, retention form. So you can first prepare your cavity. You need to remove the caries, extend the preparation to sound tooth structure. You might need cuspal coverage in posterior area. With indirect restoration, you should maintain 1.5 millimeter above the bulb if possible. So try to use indirect bulb capping in extensive caries, liners, resin with glass enamels. Under composite is good to bond to root and deep dentin. Enhancement of retention form is required. We can use any type of retention mean that we speak about to enhance the final retention and resistance form. After we finish our cavity design, we will place the matrix, the same that you use for amalgam. You can use it, auto matrix, universal, cover ring. All of those can be used with composite. Then you will etch and prime. You have different choices of material you choose. Then you will apply your composite in increment. Try first to restore the proximal surfaces, the buccal and lingual, and then you will continue with the cusps and other anatomy inside the tooth. You will finish and polish the composite. Now, the good thing with composite that they are more user-friendly than amalgam. They will, you can modify them, contour large composites after you finish. After you make light curing, you will make your normal anatomy and adjust the occlusion. So if you don't have the skills to use amalgam, I prefer that everybody try to use composite for large restoration in posterior area or area that have heavy occlusion. I prefer that using composite to restore grossly carious teeth be like a foundation that will be covered in future by an indirect restoration. Finally, the indirect restoration, we have all type of choices. We have full coverage, we have all ceramic, metal, full metal, whatever We will learn in crown and bridge next year, inshallah. So indirect restorations is a choice for treatment of grossly carious teeth. It could be using a foundation, or it should be using a foundation on those teeth with either amalgam composite or resin modified glass ionomer. Then those restoration will cover the tooth to protect it from further damage. We have many references for this lecture. I will put them in e-learning also, you can refer to them. And we will have, now the material today cover 2 lectures for this week and the week after, so I will give you 2 quizzes that should be submitted after, I think, 9 days from now. I will send you all the details, inshallah, by email, WhatsApp, and e-learning. Thank you for your attention. If you have any question, please send me an email, and hopefully I will respond as fast as I can. Thank you.